Hello everybody, this is Dr. Nadeem and we are with Neelam Path Lectures, the Pursue series. As you are aware, all our lectures are available on YouTube, which is freely downloadable. We also have a Telegram group. You can join this group. It is very helpful for accessing all lecture-related information. We have a Google Drive where the PDF of all lectures are available and a master integration key by which you can navigate between the PDF and the YouTube. We invite people, speakers, doctors, pathologists to come and give lectures on this platform. These are the disclaimers. We are with phase 3, which is recorded pathology lectures. Today we have pursued 3O, which is soft tissue and bone tumors, and we are streaming from Kolkata. The topic of the day is fibro-osseous lesions of bone. And to talk on that, we have Dr. Bhaskar Mitra, who's MBBS called Kolkata, MD, DNB Pathology Gold Medalist, a consultant histopathologist at the famous Tribedi and Roy Diagnostic Center. He's got multiple publications in indexed national and international journals. He has served as an assistant professor in the Department of Pathology at MMC Hospital, West Bengal Medical Education Service, West Bengal, advisor clinical research at IIT Kharagpur Medical Sciences. He's got multiple publications. He's a reviewer of various journals, member of IAPM and CAP. With that, I would request Dr. Bhaskar Mitra, sir, please start your lecture.
Hi, good morning everybody. Today I am back with more about bone pathology lectures. Previously I discussed about the osteoid forming tumors, cartilage forming tumors, giant cell containing lesion. Now today I will be discussing about the fibro-osseous lesions of the bone. From the name suggests, it's a fibro and osseous. So there is a dual component, presence of fibrous tissue along with the osseous thing in a variable component. Now there comes the most important part of this presentation, the how we often face problems while getting a slides of the fibro-osseous lesion in determining whether it is a soft tissue lesions having calcification or ossification, or it's a pure bone lesions having a fibrous component in the lesion itself. So in that case, the main clerk of the thing is to be determined by the radiological factor, where the radiology will tell whether the lesion is directly originating from the bone or what we call a primary bone lesion, or its epicenter is in the soft tissue. So it's a soft tissue having the ossification. Now today we are discussing about the fibro-osseous lesions, means a primary bone lesion having a fibrous component in it. Now something recapitulation of my previous lessons, that is what are the cells of the bone tissue. These are the osteoprogenitor cells or the lining cells. There are the osteoblasts, which are mainly present on the surface of the bone, osteocytes present within the lacunae, bone lining cells and the osteoclast. This is the geotopical presentations of the this bone lining cells. This is the mesenchymal stem cells. From there develops the osteoprogenitor cells, osteoblasts, and the osteocyte lying within the lacunae. These are the bone lining cells. These are the periosteal and the endosteal cells. And here comes the another different genera of cells, that is started from the granulocytic monocytic series, forming the inactive osteoclast to active osteoclast. Now this is the picture showing the osteoblast lining the bony trabeculae. These are the resorption bay or the house-shaped lacunae where the osteoclastia are present in, and they are acting in remodeling the bone, and there comes the osteocytes present within the lacunae. All the cells are connected to each other with the presence of gap junctions. Now on the both side of the trabeculae, usually we find the marrow spaces or some amount of loose connective tissue elements. Okay, now if this organization is hampered or there is a defect in the ossification, we call them as a fibro-osseous lesion. So fibro-osseous lesions are characterized by replacement of the normal bony architecture by collagen fibers and the fibroblast with the variable amount of mineralization or calcification. Now these lesions may be a developmental lesions or maybe a dysplastic lesions or any reactive lesion against any inflammatory condition, or it may be a neoplastic thing, and each of the lesion behaves differently. Because of the histological similarity between these diverse diseases, a proper diagnosis requires a great history of the patient, means how many times from when onwards these lesions are they slow growing, etc. The clinical presentation of the case and the radiographical findings are the most important factors. Now, with the previous thing, we are telling that there are different things. First is the fibrous dysplasia. This is a actually developmental disorder. Then comes the reactive lesions of the bone, and these fibro-osseous lesions are more common in the craniofacial bones, particularly the maxilla mandible regions. So here comes the reactive changes, particularly of the tooth bearing area or periodontal origin lesions, like the periopical cemento-osseous dysplasia, focal and florid type. Then comes the fibro-osseous neoplasms. In this comes the pure spindle cell proliferation forming the neoplastic lesions, as we call it fibroma. It may be of variable mineralization. As per mineralization, it can be classified as cementifying fibroma, ossifying fibroma, or in variable combination of cemento-ossifying fibromas. So this is the fibro-osseous lesions, and the main crux of the thing is that where there are bony tissue is replaced by the fibrous tissue with or without the calcification on them. So variable amount of mineralization is seen in these lesions. There are some common features. First, these lesions are painless lesions, usually slow growing things. They are bony, hard in consistency, and they causes asymmetry in the skeletal structure of our affected bone. It mostly arises from the maxilla or mandible region. Particularly mandible is the most common site, as this is the tooth bearing area and weight carrying areas. It is more common among the females. Particularly 2nd to 4th decades are the most common site of time for the development of these lesions. So as I said previously, the fibro-osseous lesions can be divided into a developmental lesions, that is the fibrous dysplasia. There is the cemento-osseous dysplasia, which is a reactive lesion, and for the neoplastic condition there are the ossifying fibroma. So histopathologically, what we see in the every cases of these fibro-osseous lesions consist of a cellular mesenchymal tissue. Most important part of this lesion, cellular mesenchymal tissue consisting of fibroblast, collagen fibers with numerous blood vessels. There may be a mixture of woven bone, lamellar bone and cementum-like material. So the radio opaque areas may be there, and there may be the radiolucent area in these cases. Now something about the molecular genesis of these things. Now there are two molecules. There is a GNSI mutated things. They mainly act on the bone mesenchymal cells. Once this gene GNAS get mutated, it forms increased amount of cyclic AMP, and that has got a both osteoblastic effect and the profibrotic effect on the osteoblast. So the normal osteoblast becomes more and more dysplastic, with having a osteoblastic proportionate due to the presence of these osteoblastic factors, and the profibrotic effect on the extracellular matrix material so causes deposition of the extracellular matrix material and giving rise to dysplastic fibroblasts. Gradually it becomes activated myofibroblast and produces and deposits more and more extracellular matrix in the stroma, giving rise to the fibrous component of this fibro-osseous lesion. So there is a defective osteoblastic activity along with the presence of fibroblastic activity causing this fibro-osseous lesion. By the side by side, there is a osteolytic activity was stimulated by the presence of this Rankel, OPG and MCSF molecules, which I have been detailedly described in my giant cell containing lesions. So there is a pro-inflammatory conditions causing increased release of interleukin 6, which causes more and more resorption by the activation of the osteoclastic giant cells, and they causes more resorption and the defect in the different bony component or the bony architecture of our body. So fibrous dysplasia, the first one, the developmental one, is an asymptomatic regional alteration of the bone in which normal architecture is replaced by the fibrous tissue or non-functional tuberculi like osseous structure. It may affect a single bone or it may affect the multiple bones. Depending on that, there may be monoosteotic fibrous dysplasia, there may be polyosteotic fibrous dysplasia, and there is a defect in the GNAS1 gene, that is the guanine nucleotide binding protein alpha stimulating activity polypeptide thing. Now this fibrous dysplasia disease may be associated with the cafe owlet skin spot giving rise to syndrome, that is the Jaffe-Lichtenstein syndrome, or there may be associated multiple endocrinopathies giving rise to McKeown-Albright syndrome. So during the mutation of the early embryonal life, it may affect the osteoblast giving rise to the fibrous dysplasia. It may affect the melanocyte giving rise to cafe owlet spots, or there may be defect in the endocrine cells giving rise to different polyendocrinopathies. So this is the cyclic MP pathway causing the fibrous dysplasia, which I have already been discussed with the schematic pictures. Now this is the actually jawbone affecting this fibrous dysplasia giving rise to this large type of lesions in the jawbones and causing facial asymmetry on the both the sides. It may be affecting the mandible most commonly, maxilla, other intraoral swellings are most common there. There may be association of this occurrence of this lesion within the sphenoid or the occiput bone. Usually it is not well demarcated lesion. It has got a diffuse radiopaque ground glass appearance in the radiology. Here the margin of the lesion get diffuses with the surrounding tissue. It may affecting the periodontal space with the loss of lamina dura in these cases. This is the cafe alert spot characteristically seeing the endocrine different endocrinopathies, among which there may be sexual precocity in the early age group of these patients. So they present with following things: craniofacial area causing this diffuse ground glass appearance, radiopaque lesions giving rise to the lesions. There is again the radiopaque lesions. There is again the radiopaque lesion causing the bony asymmetry, and this is are the lesions where we radiologically see in fibro-osseous dysplasia. Histologically, what we see, there is a defective bone formation, so irregularly shaped immature bony trabeculae, loosely arranged and present in a background of loosely arranged cellular fibrostoma, giving rise to a Chinese letter or curvilinear appearance. These osteoid areas are not rimmed by the osteoblasts. This is the picture showing this defective osteoid formation where the osteoblastic rimming, what we see shown in the classical thing, is lacking here, and it is set in a fibrocollagenous or fibrous tissue background with a proliferation of the fibroblast and the spindle cells in the background. So there is a defective osseous formation with the proliferation of the fibrous tissue giving rise to fibrous dysplasia. So this is again the fibrous dysplasia picture showing different appearance of the new bones, and there is a lack of osteoblastic rimming at the periphery of this osteoid formation. The osteocytes are there, and the defective osteoclastic activity by these osteoclastic cells are also present in this lesion. Next comes the reactive one, the cemento-osseous dysplasia. It particularly affects the tooth-bearing areas of the jaw. It associated with periodontal ligament origin. It may be periapical to situated to the only one tooth. It may be focal involving one or two adjacent tooths. It may be florid involving one of the segments, or there may be gigantiform cementoma forming a large mass involving the whole jaw lesion. Cemento-osseous dysplasia, as I said, occurs in the tooth-bearing areas most commonly. So this is the focal cemento-osseous dysplasia, particularly affecting a single tooth. Here the most important history of a kid's tooth, previously, now it's being associated with this radiopaque lesions on the root of the tooth, is very characteristic of a cemento-osseous dysplasia. Again, here we see the tooth with a presence of lytic to opaque type of lesions in the periapical zone of the tooth. Now this is the more larger lesions involving both the fragments, both the segments of the jaw bones, giving rise to the florid cemento-osseous dysplasia. Histologically, there appears the spindle-shaped fibroblast with the islands of calcified surrounded by the fibrocollagenous connective tissue. This is a densely cellular fibrocollagenous tissue proliferation. This is the thing. Here we see a predominant presence of cellular fibrous connective tissue component arranged in the whole pattern with a spherically arranged calcified the cementum-like epithelium. Important thing, each and every student every time asks me how to differentiate between a cementum and the osteoid. It is very easy. The osteoid contains the lacunae and which contains the osteocytes. But the cementum is just a blob of calcification. It's a kind of dysplastic calcification what we see. So here we won't find any osteocytes within this calcified areas. So these are the calcified mineralized fibrous tissue. This is seen in the cemento-ossifying fibroma. At places there may be ossification, so there is cementum and there is ossification. So this is the with a fibrous tissue in between. So this is called cemento-ossifying fibroma or osseous dysplasia. Again showing this cementum-like material calcified area with a fibrocollagenous tissue. At places it shows ossification. So this is cemento-osseous dysplasia. Remember, it's a rheumatic condition, asymptomatic and incidentally detected. Then comes the neoplastic component of these lesions are the ossifying fibroma. It may be two types. Due to presence of ossification or the pattern of ossification, it has been divided into two types. One is the trabecular type, another is the psammomatoid type. Both these things occurs in the very younger age group. It's a growing tumor, but the slow growing tumor. It involves the particularly paranasal bone. When during the grossing we cut the lesions, we found a fleshy and a firm type of lesion, and it's a very well circumscribed type of lesion. Painless, slow growing mass involving the craniofacial bone is very characteristic of this ossifying fibroma. It may be in an aggressive form involving more and not the more bones. There lies the, as the name suggests, it's a fibroma. So it has to be a fibroblastic proliferation or a fibrous tissue tumor. So we get a spindle cell abundant cellular fibrous connective tissue stoma arranged in holes with the presence of fair amount of proliferating fibroblasts which may contain spicules of bone or areas of cementum-like dystrophic calcification. This calcification may be psammomatoid type, that is in a holding pattern, or it may be long elongated trabeculae. So according to this, they are differently named. There are presence of multiple numbers of multinucleated giant cells. So again, this lesions comes also in the differential diagnosis of multinucleated giant cell containing lesions. There is a trabecular variant showing irregularly strands of highly cellular osteoid encasing by the plump osteocytes. There may be psammomatoid pattern. Radiologically, these lesions are radiolucent as the bones has been replaced by the fibrous tissue. So these lesions are radiolucent, but at places due to ossification and calcification, there may be radiopaque appearance with a ground glass appearance of this lesion. This is the jawbone showing both the osteolytic and the a bit of opaque areas. Again, this is the osteolytic lesion, and but the lesions are very well demarcated. As we can see, the lesions are very clearly seen. Now, Here comes the fibrous tissue. Here in the three pictures I have shown the different amount of fibrous tissue proliferation with presence of prominent fibroblasts. Here you can see how prominent is this fibrous component. Along with this, there may be different areas of cementum or osteoglide formation. So it is a fibrous tissue tumor or fibroma getting metaplastically ossified. So it's called ossifying. If it contains cementum, then it's called cemento-ossifying fibroma or ossifying fibroma as per the amount of presence of cementum and the osteoid material. As this affects most of the patients are younger age group, about mean age of 11 years. So they are again can be called as juvenile trabecular ossifying fibroma, JTOF. And these are the well demarcated tumors composed of trabeculae of open bone rimmed by osteoblast and osteoclast lying in a fibrocollagenous stromal component. Now comes this lesion. This is called cherubism. Cherubism is nothing but a abnormal bony lesion where the bone has been defected, the development of the bone has been affected due to an autosomal dominant mutation condition by a multiloculated cystic and forming a multiloculated cystic lesion. Here the bone has been replaced by the fibrous tissue and there is a defect in the 4p16 gene. So there is a painless bilateral swelling in the mandibular region affecting the lemmas at the angle. They may be bilaterally symmetrical lesions and giving rise to the typical characteristic facial appearance of these patients. They may be sometimes associated with a cervical lymphadenopathy. So these cherubs are nothing but the plum-checked little angles. As the lesions grows, this symmetrical proliferation may regress or sometimes it may stay. So with the development, these lesions go away. So it's a developmental anomaly, nothing to worry about the formation of a cancer. So there are multiple, this causes the defect in the bone architecture. There may be multiple unerupted or displaced tooth. So sometimes they are called the floating teeth appearance. The teeth are here and there within these multiloculated cystic areas. Histologically, it shows the presence of multiple giant cell containing lesion lying within a fibrous connective stoma. There are multinucleated giant cells with the loosely arranged stoma and there may be small number of giant cells. There may be eosinophilic cuff around the blood vessels of these lesions. The metabolic factor, that is the serum calcium phosphate alkaline phosphatase, remains normal in comparison with the brown of hyperparathyroidism. As we've shown, it again shows a multinucleated giant cell containing lesions with areas of hemorrhage, as that's why they are called the brown tumors. Here, if we check the parathyroid hormone levels of the body, where we can find high amount of PTH level in this body, but which is absent in cases of children. This is the central giant cell granuloma, particularly affecting the jaw bones. It is a cellular fibrous connective tissue containing plump spindle cells with the clusters of multinucleated giant cells with the presence of hemorrhage and hemosiderin containing area. There may be reactive uven bone or trabeculae of bone may be seen. These lesions has to be separated from the other giant cell containing lesion, particularly the central with comparison with the peripheral giant cell lesion. First of all, I will like to say that the peripheral giant cell lesion and the central giant cell lesion histologically very similar. So you cannot differentiate on the histology. If the lesion is primarily involving the bone or it's a osseous lesion, then it is the central, and if it is involving the jaw bones, extraosseous lesion, particularly the gingiva and the alveolar regions, then it is the peripheral giant cell containing lesion. Histologically, it has to be differentiated from the giant cell tumor of the bone, where the giant cells are distributed throughout the lesion, but here in the giant cell containing lesions or giant cell granulomas, the giant cells are arranged in the small nodule or the cluster within the lesions and surrounding fibrocollagenous tissue proliferation. These are the different types of fibro-osseous lesions we come across, like the fibrous dysplasia, cemento-osseous dysplasia, ossifying fibroma, and juvenile trabecular ossifying fibroma. For the examining batch, I will like to say this is the 4 slides you have to be learned by your heart, so that this when this things comes in the exams, you will be ready with this. And this is in a small from the book page. I have scanned this page and put in my presentation. It's a small note kind of thing, giving rise to a summary to the all the lesions I have already discussed. So, and in the final part, I will like to see the how to approach these lesions. First, we will see what we see in this fibrous lesions: the bone component and a stromal component. So, first you get a fibro-osseous component and a fibro component. Now you have to see whether you are seeing any bone or a cementum, that is whether the presence of osteocyte is there. If the osteocyte is there, it is a bone, and if it is not there, then it's a cementum. Now whether if there is a bone and the presence of stroma without osteoblastic ribbing, then we call it a fibrous dysplasia. With osteoblastic ribbing, we call it fibro-osseous dysplasia. Now, if there are numerous osteoblasts, it may turning out to be an osteoblastoma or aggressive osteoblastoma, or sometimes it may be malignant osteoid present there, giving rise to osteosarcoma. And if the giant cells are present, look out for the parathyroid hormone level also. If there is a high parathyroid hormone level, then it is a brown tumor of hyperparathyroidism. If there is a giant cells containing lesions with a central nodular aggregates of this lesion, then it may be a central giant cell granuloma. Or when there is a predominance of the stromal cells, and that is a neoplastic proliferation of the stromal cells with a presence of diffuse distribution of the giant cells throughout the lesions, then we call it the giant cell containing tumor of the bone. So this is how we approach to the fibro-osseous lesions. I think I have made elaborate discussion of the fibro-osseous lesions and how to differentiate each of the thing. Following this thing, this will help a lot in the differentiating and diagnosis in the fibro-osseous lesion, both in the exams and also in the practical life in our day-to-day practice. So thank you everybody. This is the different type of fibro-osseous lesions we see come across here. The key factor is you have to appreciate the dual component of presence of fibrous as well as the osteoid. So thank you everybody for listening this my lecture. I will be soon coming with the more lectures on the how to approach the small cell containing tumors of the bone and the miscellaneous one in very quick time. So thank you everybody for listening this lecture. Thank you.